Thank you again so much for this opportunity. My name is Xin Xin Yu, and I work in clinic as a movement disorder neurologist and the medical director for our FMD clinical program. Very thrilled to be here and also very humbled as well. My topic for today is on semiology or phenotype of functional movement disorders. And before actually this presentation, I want to maybe follow up with one of the questions to Dr. Hallett earlier regarding the mirror box. And our team actually is in the process of publishing a manuscript on a pilot study on the mirror box for functional tremor. It's actually a very small study, a pilot study. We actually just used a one-time intervention using the mirror box, and unfortunately, it was a negative study. There were some mixed results, and we're really hoping to share that with the community once this is publicated. And but let's dive into the presentation here. So FMD is really a big topic, and it has so many different subtypes. And for the purpose of this talk, we'll stay focused on functional movement disorders. We will start with a case study, followed by we'll go over available diagnostic criteria for functional movement disorder, and then we'll dive into each phenotype and their characteristics, and then end with some special considerations. So this is a true case from our practice. This is a 35-year-old woman. She had a history of epilepsy since childhood. She developed sudden onset, intermittent, jerky movement, and also spasms and contortions of her trunk. She was admitted in the epilepsy monitoring unit to try to capture these episodes, and there were no EEG correlation associated with this abnormal movement. And based on the appearance, she was thought to have a dystonic phenomenon. Her neuroimaging was unremarkable, and there were no exposure to dopamine blocking or depleting agent. And here are some videos. On exam, we found the patient had paroxysmal jerking and lateral and extensor posturing of the trunk. She was awake and aware, but she was very uncomfortable. The jerking movement had variability in terms of the amplitude and frequency and duration. I had her walking the hallway of our hospital, and I was watching her posture and watching her gait. We tried a number of different distraction techniques. Here she was trying to show me where she felt the spasm the most. We tried actually a suggestible technique and also mindfulness exercise as well as we were just walking down. And you can see her posture start to normalize when she was following those instructions. She was really thrilled to see the change in her symptom severity just during this one-time session. When we came back to the room, we discussed the diagnosis of FMD and explained how we reached the diagnosis, and she was very eager to start therapy. As the presenter previously noted that in the US, at times it's hard to get insurance to approve an inpatient rehabilitation. So for this patient, she went through the outpatient treatment with our FMD team, including physical therapy and psychology on the outpatient basis. And after a year's time, she was doing really well with complete normalization of her movements. I want to point out that diagnosing FMD correctly and explaining that with the patient in an understandable way is really the first step in getting patients on the right path. There are several sets of available diagnostic criteria that share some commonalities, but also have some differences in terms of areas of emphasis. But mostly, I would say that they're based on the following key items: historical clues, positive exam findings that reveal inconsistency, and incongruence with other known neurological conditions. So we'll quickly review these available diagnostic criteria in more detail here. The Fawn and William criteria really has been serving the most common tool that's being used in a lot of clinical and research setting. It does emphasize the inconsistency and incongruency, and also historical clue and presence of emotional disturbance. As you see in the column of clinical possible definition, it is based on the Fawn and William criteria. It's based on presence of emotional disturbance alone, which can create some controversy and some concern for potential misdiagnosis, as many other organic disorder can be associated with emotional disturbances. There's also a category of documented FMD, which is defined as remission with placebo. It's not common nowadays to practice placebo outright, but however, this is similar to situations where we may see immediate or dramatic resolution with certain interventions that cannot be explained physiologically, such as we may see immediate resolution with botulinum toxin injection that may not be explained physiologically with the results within a few hours. Schill and Gerber criteria added additional criteria items that they propose may replace the need to identify a movement disorder as inconsistent. So those features include excessive pain, fatigue, exposure to disease model, potential for secondary gain or multiple somatizations. However, as you may imagine, this also have created some concerns for potential misdiagnosis if we take out the inconsistency criteria. Gupta and Lang criteria, the differences is that on top of some of the Fawn and William criteria components, it did not require the non-motor features to be part of the clinically definite criteria. And also, the other difference is that they also introduced a laboratory-supported definite criteria with electrophysiological testing confirming certain phenotypes. Finally, in the recent years, phenotype-specific FMD diagnostic approach has been proposed and advocated by Espay and Lang, which really exclusively rely on positive clinical finding, careful neurological examination by a movement trained neurologist, as they felt that some of the supportive features, such as historical clues or psychiatric comorbidity, do not rule in or rule out any disorder with certainty. For the purpose of this talk, I think it is still worthwhile to review some of the historical clues that can be commonly seen with FMD. And these features include sudden and rapid onset of symptoms. The course can be fluctuating, it can be static or progressive. We might see migration of symptoms to different body parts that the patients might describe, and they might describe resolution of one symptom followed by appearance of another one. And in the history, sometimes we will also hear about high placebo response or suggestibility. We may find coexisting psychiatric illness or multiple other somatizations as well. Some of the other characteristics of FMD include that females are more likely to be affected than males, and the reported age of onset varies widely, with a mean in the 4th decade. But a recent study have shown that the patients with dystonia and weakness subtypes tend to be younger, and those with gait disorder tend to be older. So far, we mentioned quite a bit about inconsistency and incongruence. So these are two main pillars of FMD diagnosis. So what does each mean? Inconsistency means that the movement, the phenotype, may change over time, and it may change in terms of the phenotype amplitude, the frequency, the directionality, the way the body distribution, or even severity. The movement may disappear with different distraction techniques, and we may also find that the subjective disability may be very disproportionate to objective finding. These are components of inconsistency. In order to effectively assess inconsistency, we need to observe and examine the patient over a period of time. And sometimes it may require several visits to be sure. And we also need to be open to try different distracting tasks. If one distraction maneuver did not work, we need to be creative in having more than just one maneuvers that we can try. In terms of incongruence, incongruence means the movement don't follow the criteria of other known organic movement disorder. And others advocate that this really means that the clinician making the diagnosis of FMD needs to build up and have extensive experience in movement disorder to be able to accurately distinguish functional versus other potentially bizarre presentations of organic disorder that may look like functional. So while these two are the foundation and pillars of FMD diagnosis, recognizing specific neurological signs and features to each movement phenotype will be very helpful to confirm the diagnosis. So we'll discuss some of the phenotypes commonly seen with FMD. So FMD can manifest with any type of abnormal movement, and including tremor, dystonia, gait disorder, myoclonus, tics, Parkinsonism, or a mixed type of these different phenotypes. The largest FMD data set was made possible internationally, involving 70 authors on this FMD phenotype study with close to 5,000 cases. And in this data set, the mixed phenotype were the most common, followed by tremor, weakness, dystonia, gait disorder, and others. You can see on this graph the distribution of the phenotype follow roughly the same trajectory in a non-normal distribution, and have a peak in the midlife, and really regardless of the number of cases for each phenotype. But it is from this study that they found that the dystonia and weakness patients tend to be younger, and those with gait disorder tend to be older. This study of 100 patients with FMD were longitudinally observed over 3 ± 2.5 years on average. What these authors found was that during observed time, about 50% of patients had change of the phenotypic pattern during their course. And the mixed phenotype were the more likely to develop additional symptoms, while the dystonia phenotype had the tendency to remain unchanged phenotype over time. However, for those without any phenotypic change, many of these patients still had change in their symptom severity. They may have relapsing remitting pattern or progressive course. For example, those with isolated focal dystonia may progress to segmental or hemidystonia. Let's dive into each phenotype. Functional tremor by far is the most, outside of the mixed subtype, is the most common phenotype of a specific functional movement disorder. The core features of functional tremor, number one, variability. So variability can be assessed with tremor frequency, looking at the tremor frequency, distribution, directionality. It's important to observe the tremor throughout the visit, including during history taking, which you may find there is a variability in the overall phenomenology. And as I mentioned earlier, sometimes it is necessary to see the patient more than once to get a clear picture. Second is entrainment. Entrainment can be demonstrated when the patient is asked to perform a repetitive task with, say, a non-affected hand, and the affected hand might adopt the frequency of the tapping task. And tremor entrainment is really incongruent with any other known tremor syndrome. Thirdly, distractibility. Distractibility means reduction or disappearance of the tremor with a distraction technique. And the distraction technique can be done using cognitive tasks. They can be used a motor task. The common ones can be mental subtractions, serial sevens, having the patient use their finger to chase after a moving target. The one that I tend to use is a Luria test, like to incorporate as a distraction maneuver as well. And so you can get very creative with this. It's important to note that sometimes functional tremor can be difficult to distract. And because sometimes patients may have a hard time focusing on that particular task that you're asking them to do. So they perform the task poorly, therefore the ability to detect the distractibility is lost. So poor task performance can also be viewed as a positive sign for functional tremor. Another core feature is co-activation or co-contraction sign. This is seen when the antagonistic muscle activates, when the tremor pauses and right before it reemerges. And this can be demonstrated also using electrophysiology testing. When you see a brief pause or reduction of the tremor amplitude, when you have the contralateral hand to do sudden ballistic movement, this is also can be a diagnostic clue for functional tremor. There are several others that have been reported, including the whack-a-mole sign. This is when one is trying to actively, forcefully restrain the body part that is tremulous, and then that creates the spreading of the tremor to other body parts. Functional tremor can also be suggestible, and it does vary in response to certain stimulus, such as touching a trigger point, and the patient may have a strong suggestibility and their tremor may change, reduce, or disappear. So in this video, several features are demonstrated here, including variability of the tremor frequency and amplitude. And you also will see that the tremor will disappear with tongue movement as a distraction technique. So some of these core features can be confirmed using electrophysiologic tools. For example, take a look at the accelerometry waveforms at the bottom right. This is a patient with a right hand tremor, and the left hand is unaffected. The figure 8 shows the tremor with the right hand, and you see no waveform for the left because it's unaffected. And the figure B shows that when the patient is asked to use their unaffected left hand to tap at a slower frequency, and then you start to see that the right hand, the tremors start to adopt a slower frequency. So this would be a confirmatory test. In terms of functional dystonia, and this is also one of the common phenotype, functional dystonia can be challenging to diagnose and treat. The location where the body is affected may include the foot, face, the head, the neck, and hand and trunk are some other locations where functional dystonia may occur. The core features of functional dystonia include rapid onset and fixed posture at rest from the start. And you may also find variable resistance when you passively manipulate the affected body part. You may also find distractibility and disappearance of the symptom when the patient feels they're unobserved. It's not uncommon to see secondary complication with functional dystonia, such as some of the findings that you might see with CRPS, for example, complex regional pain syndrome, type 1, some skin changes, swelling, some autonomic local responses there, even contractures. Some have argued that the fixed dystonia with CRPS1 may be an organic form of dystonia, and you also have other that may argue otherwise, as they saw some identical electrophysiologic feature that in the fixed dystonia with other cases of confirmed functional dystonia. So there is a controversy in that area. And at times we may see significant pain, and that is actually a supportive feature, even though we need to be cautious that there are organic dystonia that can be accompanied by pain, for example, organic cervic dystonia. Here are some examples of functional gait disorder presentations. So a patient with functional gait disorder may present with bouncing gait in the first video. They may present as excessive slow gait and walking as if they're walking on ice. And knee buckling, very suggestive of functional gait disorder. And some may have this uneconomic posture that is not energy efficient. And here are some other presentations as well for functional gait disorder. Astasia beige, for example, highly suggestive of functional gait disorder. And it may be accompanied by other FMD phenotypes, such as, in this case, functional jerks that you can see. And sometimes patients may demonstrate effortful gait and may even, show huffing and puffing sign as a result of the exaggerated efforts. And as you can see, when this person turns around, you'll also see the scissoring gait, which is also a feature of functional gait. And lastly, on this video, this person demonstrated a very erratic swaying without falling. Although I do have to say that, well, it is less likely for patients to fall with FMD, but there are some patients that do have falls, either with or without injury. Now, moving on to functional myoclonus. The core features of functional myoclonus include suggestibility, variability in duration. I can see variability in the distribution of the jerks, and also variability in the latency if there's a presence of stimulus. In the first video, you might appreciate the variability in the body distribution, as well as the variability in the duration of the jerks. Some are quick and some are slower jerks. And he also here demonstrates entrainment with repetitive finger tapping. And in the second video, the jerks occurred in various body part without any specific pattern. Could be in the left arm, the trunk, the head, and then you'll see some leg jerks as well. So I gave him a distraction test there, and the jerks were fully suppressed. And you saw that the jerks immediately return after the distraction test end. So similar to functional tremor, functional myoclonus can also be confirmed with electrophysiology. For example, surface EMG can document the variable duration of the bursts of the muscle contraction, and they tend to be longer than the organic myoclonus. And it's usually longer than 250 milliseconds. And you can also document a Bright shaft potential, which is a negative pre-movement potential using EMG-EEG back averaging. Next, some examples of functional Parkinsonism. So the core features of functional Parkinsonism include excessive slowness during examination. Let me play these videos together here. The slowing that patients exhibit really doesn't have the decremental feature. For example, you'll see in this second video, as the patient is instructed to tap their finger, it's really uniformly slow without any decrementing that we might see with Parkinson's disease. Patient may report stiffness in their arms and legs, and you might find stiffness to passive manipulation, but the stiffness is not associated with cogwheel, and it really cannot be worsened by contralateral activation, again, that you might see with Parkinson's disease. And patient may also exhibit a resting tremor that appears variable and distractible that we discussed earlier under the tremor segment. And for assessment of functional Parkinsonism, a dopamine transporter scan can also be a helpful tool. But oftentimes, relying on these positive clinical findings often are sufficient to help us to make a diagnosis without using any other redundant testing. I'd like to talk a little bit about some special considerations. It's important to note that bizarre movements don't really automatically equate functional movement disorder, and this is one of the pitfalls. Many organic disorder may have some very unusual or very bizarre characteristics, and here are some examples. So this is a patient diagnosed with Parkinson's disease at age 35, and he had a positive response to levodopa, and he developed this very bizarre dyskinetic gait pattern associated with the on time. And this person actually did well with deep brain stimulation. And here is another example of some bizarre appearing movements, and this is a man with dystonic and choreic looking gait. So he actually developed hyperkinetic movement disorder along with dysarthria, dysphagia, and some cognitive symptoms since age 26. And he was subsequently diagnosed with neural acanthocytosis. And he also went through deep brain stimulation with some improvement with his hyperkinetic movements symptoms. So what phenotype are these? Let me play each one. So would you classify this as a tremor? Or maybe myoclonus? The tremor would be regular, would be rhythmical, would be oscillatory, but it doesn't really fit with that. And how about this? So it appears to be kind of a tremoring phenomenon. But then there's also some jerky components to it. So my point is that they really don't fit with any specific phenotype, not truly myoclonus nor tremor. So this is a problem that was raised and discussed by Dr. Stephen Frutt, movement specialist and professor in NYU. In a presentation that he did, I want to share that here. And he talked about the issues with the current FMD phenotype classification and terminology. And he argues that the organic terminology, for example, myoclonus, dystonia, all have specific definitions. And the appearance of functional movement disorder don't exactly fit with their organic counterpart, which is actually the concept of incongruence that we've been talking about. But using the same terminology as equals is like trying to fit a square peg into a round hole. Dr. Frutt talked about how this might be confusing to patients in terms of trying to understand the diagnosis and treatment. And the patients may wonder, why am I not going through all the workup for myoclonus? If you're calling it myoclonus, or if you call it dystonia, why am I not getting all the genetic workup? So, and he raised concern that this may contribute to redundant and some unnecessary workup for these organic counterparts. So he proposed that we may consider using patients' own description of their symptoms and simply call the movement for what they are: shaking instead of tremor, jerks instead of myoclonus, spasm instead of dystonia, and slowness instead of Parkinsonism. So what do you think? And I will leave this as food for thoughts. So some take-home points here. Here's some in regarding to FMD diagnosis and semiology. To make the proper FMD diagnosis, we must assess and determine if movements are inconsistent over time, and if they are incongruent with any other known organic movement disorder. We must look for specific signs and core features of FMD to rule in the diagnosis. And lastly, we also need to be very careful with some of the bizarre presentations of organic disorder so that we don't fall into those pitfalls. Thank you so much for your attention and for the time. And again, thank you for allowing me to be here with you today. And I'm open for questions now or later in the panel discussion.